I'm expecting one or two others, but I think with respect to everyone's time, we're going to go ahead and get started. So we'll call the meeting to order at 2:02. And just a quick note, this meeting is being recorded and will be available for viewing on the Judicial Branch YouTube. Hi, Robin. We were just getting started. So everyone should have the agenda and the minutes from the January meeting, January 11th meeting. But before we get, yes?
I'm counting. I'm not certain that we have a quorum yet. Do we?
So we have, let's see, Brittany, Robin, Beth, Dr. Cordiano, Rachel, Sherry, and myself. I have a quorum as being 6. Is that correct, Brittany? If you have quorum of 50%.
Right.
Yeah. Okay.
Thank you.
Yep. So we'll go ahead and get started. And before we get started, I do have an introduction to make. Robin Vincent is our new administrative assistant. We want to thank Jean Wosbrud, who's been taking the minutes for us for, since the very beginning. Jean, the last, what, 3 years?
Yeah, it's been 3 years.
Yeah. So Robin's going to be taking over from her, and there's Robin right there. Robin has been instrumental in a lot of things over the last couple of months, and she came to us from the medical examiner's office, where I think she just kept them in order over there. So now she's keeping me in order, and so she'll be taking the minutes for us. The next thing we want to do is actually do the minutes, the approval of the minutes. So do I have a motion to accept the minutes in a second?
This is Beth. I'll make the motion.
Okay, thank you. And who seconds?
I can second,
Robin
I'm
here.
sure.
Who is that?
Robin,
Okay.
the other Robin.
Yeah, okay. Yes, we have 2 Robins here. So discussion, any questions or discussions on the January minutes? Corrections, edits? Okay, by a show of hands. Yes, I know. All right, we'll accept any. Well, let me ask you this before we accept them. Any nays? Abstentions? Okay, they are approved. So if you look at your agenda, you'll note that we're going to do an update on the DPH pamphlet, and I'm going to ask Robin and Beth if y'all could let the committee know. Robin, I'll let you go first.
Thank you. As you can all see, I'm from the Department of Public Health. I can't hide. And after this, I'm going to put myself on mute and close the video because I don't know if you can hear it, but they decided without telling us to cut down a tree outside today, and you're grinding it all up. So anyway, just to keep the noise down. So here's where we are with the brochure. And of course, Beth can chime in. Beth and her group made the corrections that they felt were necessary that they could do. And then right now we have some interns from the CDC Foundation with us. So one of them who's very astute at resources, she's actually working with Planned Parenthood of Southern New England right now for us. She is working on the bigger resource list with all the other rape crisis centers resources. So she's made pretty good progress. There's some things that she's having trouble with. She can't get QR codes for everyone. So, so we'll have some incompletes, but I don't think we'll be able to do any better. So she and I will go over that. What's today? Wednesday, hopefully before the end of the week. So we might finally have a version that we'll be happy with. There was some language in it that, and Shanae, who's the person working with me, also noticed sometimes it says sexual violence, sometimes it says sexual assault. Do we need to make that kind of thing uniform?
So I can answer that really quickly if it's okay to chime in. Part of that is about when it is referring to a crime, there is a crime, like, you know, in terms of somebody seeking services who might be interacting with systems-based folks, we tend to use assault. So we can clarify and go back through. We do like to broadly use the term sexual violence because it encompasses a wide range of behaviors and experiences, you know, for survivors to reflect and identify along that continuum, excuse me. But I think that there are certain spaces, if I'm remembering correctly, where we used assault because that would be the language that would be reflected in a systems-based setting, if that makes sense.
Sure. I just want to be sure it's correct and people aren't picking on us for not doing this or not doing that. So maybe after Shanae gets all the resources in order, we can take another look at just to be sure that the language is accurate for us. I know it's taken forever.
That's okay. We're getting a really good product in return.
Thank you.
So I have
Okay.
a question to you and Beth. Is there going to be an opportunity for the committee to read it?
Oh, absolutely. I would never, you know, send it to print before you all got to look at it.
Okay, okay. Do you have any idea when that would be?
I'm hoping by the end of the month.
Okay, I was thinking of in terms of the May meeting, because it would be lovely if we could have it to review before the May meeting.
Okay. All right, I'll work on it.
Thank you so much. And I see Heather.
You're more than welcome.
Anything else? Any questions for Robin or for Beth about that? Okay.
Could I just add one thing? This isn't
Sure.
about the brochure, but I can't remember dates anymore. February 8th in collaboration with the Alliance and the Connecticut Domestic Violence Group and the Community Health Center Association of Connecticut. I'm missing somebody. But we sponsored a webinar on teen dating violence. We do something similar every year. February was Teen Dating Violence Awareness Month. We had over 200 people register. At least 120 attended. All of the evals were great. So just so you know, people are interested and committed to this. And Kelsey, they did another teen dating violence webinar through DCF, which they also had over 200 attendees. People are very interested in this topic, so just keep that in the back of your head as you move along.
That's wonderful. It's great that it's really getting out there. I think that's wonderful training. Any other questions, comments about the pamphlet? So, you know, Robin, we'll look forward to maybe seeing that in a few weeks, so we can have a chance to review it before the May meeting.
Right.
And one of the things that we want to do, and I realize I have Safes in Connecticut before the state discharge packet, and I will get to that in a minute, but we do want that to be a part of the state's discharge packet as we get closer to having everything completed. So in fact, I'm gonna exercise my prerogative as chair, and I'm actually going to switch over to this discharge packet. One of the things that we had talked about in a previous meeting, and I went back and looked at the minutes, is we have within the state discharge packet, which was intended to be available both by QR scan code as well as a hard copy packet, depending on the need of the patient. It was to be inclusive of not only the DPH packet pamphlet, but also OVS information, information from the Alliance, CCADV, Safe Connect. We talked about a victim survey. I know, Beth, you and we had kind of sort of gone back and forth about redoing that victim survey. Can you remind me of where we left that?
So if at any point someone would, the group or anybody would like to do that, we are very open to doing it. Right now, the only surveys that we do are through the SAFE program. So if anybody is going to another emergency department outside of those participating hospitals, they wouldn't receive the survey. We could recreate, we could really just have, in there's kind of like a drop down of all the hospitals. We could put an extensive list and or have a fill-in box for folks to do that. But it would be great to have data come out of the entire state. I think one of the things that also would help to do, quite frankly, as a perhaps intended consequence or unintended consequence of gathering the data, is you would see, I think, that the responses from safe hospitals would show better outcomes sometimes and probably more often than those at non-safe hospitals. So as a real support of the program, because that's what we see anecdotally with the survivors we serve. But we are at any point ready and willing to do, we have the SAFE survey already there. I don't think you would need to change almost anything. In fact, I would argue that you'd want to mirror the two surveys with one another. So we could do that at any point. We're happy to do it.
That would be wonderful. And especially if we could, I know we're doing postage paid. For those of you who don't know, the Alliance has been very generous over the years with giving us these postage paid envelopes. So it's a self-addressed stamped envelope, but they have been paying the postage and giving us the victim surveys for as long as the program has been in existence. So I really want to thank the Alliance for that. And we're hoping to maybe move over to something that's more electronic, more immediate, and basically more accessible than having to, we're kind of moving out of the age of paper, if you will. So hopefully we can get that going, Beth, and make that a part of the state's discharge packet. And I see, Robin, you have a hand up?
Yes, I just, I was wondering, perchance there's a reason why statewide the hospitals aren't participating in this?
Are you talking about the SAFE program?
Right.
Oh, we're going to get to that. That's under new business.
Okay.
Yep. And I'll give the backdrop for those who are new. I'll give the backdrop when we get to that point. So not to reiterate, but basically all of that information that I just said, the victim survey, and I also put down a question mark of kit tracking. I know that's been in the kits. I don't know if I understand from Amanda, I don't know if you want to chime in here. There's a change about to take place, yes, with kit tracking?
So the trackpad was supposed to be updated at I believe it was February 1st, and it was going to be updated to a higher security version of what the UPS trackpad already was. And when that did happen, there were some issues that arose, links that weren't working, or the link wasn't supposed to change and it did. So there was lots of problem solving that the lab was trying to do in connection with UPS. So we actually ended up reverting back to the original trackpad before the upgrade so that no one lost any of their usernames or passwords. And so now we are going to postpone that because by the end of the year, we're going to be upgrading to a completely different system that isn't associated with UPS trackpad. It's going to be a whole different system. And so that's sort of in the works now. So technically nothing has changed. It was supposed to. There were errors that came up, and now we're back to the how it's always been. It's almost as if nothing ever happened. But I'll be sure to update you all when we kind of have more things in the works for the newer trackpad system, probably by the end of the year.
Okay, thank you, Amanda. I kind of realized I put you on the spot there a little bit, and I apologize.
No problem.
But I did have it as a question mark as to whether or not that would be included in the discharge packet, or if that would continue to be within the kit. So certainly that can be a conversation for later on. Beth says it's included in the discharge paperwork given to survivors, but is not currently available electronically. Yes. So we have the ability to do that at any time, just as we go in and enter them ourselves online. And then Rachel, I see you said something. Oh, you were answering Rachel's question. Okay, all right. Thank you. So, you know, it's all a work in progress, and I really think that when we get to the end of this year, I'm hoping, but I believe that we will have a wonderful discharge packet that will be consistent from across the state, and that hospitals can also, though, and we did talk about this, hospitals can be able to also identify regional resources or local resources to be included in that. So you have your statewide discharge packet, which has all of the general information in it, but then hospitals can also add their own information to it. That would be more specific to that area. So that's in the works, and I know we had been kind of waiting for the DPH pamphlet, but now that that's really well underway and really close to being finalized, I wanted to start to move forward with the other components of that. So I'm going to talk to Linda, and Linda unfortunately was not able to be here this afternoon, and see what our capabilities are with regard to the QR scan codes. And how do you do multiples? You know, I don't quite know the science behind QR scan codes. If you can QR scan code simply a one QR code, but then that leads to another that also has a QR scan code, how would that work? So those are the questions that we're kind of looking at, and that's more of, I think, a technology issue to see what we can do versus what our limitations will be. Any questions about what we just discussed? Thoughts, ideas? Okay. So going back to safes in Connecticut, and I'm going to tag on to another thing as well that we had previously had on the agenda. It is not currently on the agenda, and that's that the website is up and running. We talked about that at the last meeting in January. That is fully functional and is on the judicial branch's website. As far as the safes in Connecticut, that has been provided. The entire list has been checked, and it has been provided to the Connecticut Hospital Association. We agreed on the wording that it is available for distribution. And that was the word they would like us to use, is available for distribution to those who qualify. It would be, you know, nurses and hospitals. If they have a question about who is on that list, or if they would like to check to see if they themselves are on that list. So that's just kind of a wrap up of safes in Connecticut. It will be updated this summer. We're about to start the spring class, and of course we had as basically, because we have 2 classes in the year, we update it twice a year. Any questions on that? Okay, well, moving right along. So we are kind of sort of at a point where we're hitting the new business aspect of things. One of the things that we brought up in the last meeting was what the plan was for the program. In statute, this is a response program, and it was, the intent of it was to be statewide. Robin, just to answer your question about why And very briefly, because it's really a 12-year history, but the long and the short of it is that we started to expand in 2016, I think it was, and the bottom fell out of the budget. We lost the expansion, which was westward, and we lost a good part of the funding for the SAVE program in that year. We built back up. We were really closing in on the numbers that we needed to start to expand again, and the pandemic hit. So that's really why, in a few sentences, why we're not across the state yet, why we have not expanded. However, a couple of things. One is we've realized that outside of the emergency department, there are in fact quite a few nurses who would like to be SAFEs and who are in the SAFE program. We've grown this program in the space of a year from 13 to 31. We continue to grow. We expect to break 40 by the end of this year, well over 40, in fact. And so I spoke to Linda after the last SAFE Advisory Committee meeting, in which the Connecticut Hospital Association and others were, everybody was on board with, and has been on board with having this be a response program. So I'm going to share something that Linda did, and I'm sorry she's not here today to really expand on this. Can everybody see this? Is it too small? I'm hearing crickets.
If you could enlarge it just a little bit.
Yeah, maybe it's smidged to me.
All right, let's see here if I can zoom. Just try. Okay, let's try this a little bit. I don't know if that's any better. Let's see.
I think if you go on the bottom, Linda, of your screen, it says like up to 82%. If you just move that bar a little bit, it would get bigger. On the ribbon on the bottom.
Down to the right.
Oh, I see. It's my. I see my.
Yeah.
There we go.
Yeah.
My
You got it.
my you know how you see your photograph kind of
Yes.
from your own little corner? It was hiding it.
Thanks.
Yep. Do you see it? And does everybody see that now? Yes, no, do I need to make it bigger?
Looks better on mine.
If I go too far, it cuts it off.
Yeah.
I think the numbers are what we really want to look at. So Linda did an overlay with the numbers. It's by county. These are reimbursements. So what we had to do was we had to pick a standard that was a consistent standard across every hospital, across every county. And reimbursements, not so much billing, but reimbursements were the key to really getting a consistent standard across. And it was a little eye-opening. You can see the numbers there in front of you. And just for sake of context, long ago, when the first 6 hospitals were picked, which were all in central Connecticut, which was, I think was Hartford Hospital, St. Francis, Manchester, Middlesex, Windham, and New Britain. Those were the original ones. It was my understanding that back in those days, they were looking at the relationships between advocates and law enforcement, as well as billing. And those were the 6 hospitals. Those 6 hospitals were picked before I say that because I was told this. This happened before I was ever in my position. When I came on board, the 6 hospitals were chosen. Then when we started to expand in 2016, we did add Middlesex, We also added Connecticut Children's because there was a collaboration between Hartford and CCMC for ages 13 and up. And I guess Hartford was, you know, they basically said something to us about the need to include them. So they were included. And then, although it's not here, the University of Connecticut Storrs campus was also added during that time for other reasons. But as you can see, and I realize the numbers are small, I apologize for that. But as you can see, most of the hospitals are kind of sort of in sync with each other. You know, Yale, Rachel, I know you said this the other day at that conference thing, but I think Yale had something like 93, 94. And correct me if I'm wrong, that I think St. Raphael's campus, which shows 0, is included in that number. Is that correct?
Yes, that's correct.
Okay.
Although that number isn't the total number. I think I'm not sure how that works. I know that we have 114 patients, but maybe those are the actual physical kits that were opened. Is that what it is, Denise?
Well, it could be if you. It's actually fiscal year that I know it's cut off up there, but it says SFY. That's state fiscal year 2022. So July 1st of 2021 to June 30th of 2022.
Oh,
so,
okay.
Yeah, that might be it.
That might be the difference in the numbers.
Yeah. So with that in mind, this will probably become something of the standard where you can have a consistency in expansion. But the way we are looking at this is that we want you as the SAFE Advisory Committee, and this is kind of sort of a task. We're going to give it to the SAFE Advisory Committee, which is also was the role of the original SAFE Advisory Committee way back when the program was first begun. The SAFE Advisory Committee was responsible for advising on not only the structure, but also the expansion. So the SAFE Advisory Committee is being given the task of planning an expansion. It was never intended for one person or even two people to be the ones that kind of sort of made the decisions with regard to this. That it was the reason for having an advisory committee. So what we are asking the SAFE Advisory Committee to do, 3 tasks initially. One is identify what should be the structure of the expansion. Is it, you know, we've talked about, I've heard hospital systems, I've also heard regional. So it'll be to identify what the structure of the expansion should be. That's task number 1. Task number 2 will be to identify the resources needed for expansion. And this does include funding. We are obviously a little more than halfway through the current fiscal year. For anyone that does not know, the state fiscal year runs from July 1st through June 30th, and the state budget is a 2-year biennial budget, and we are in the midst of that. The third task will be to identify a proposed timeline for expansion. We do not think, at least I don't think Linda believes it either, that we can do this in fiscal year 23-24. But Linda did believe it might be possible to begin the expansion in fiscal year 24-25. So, what I've asked Linda, since this was kind of her work, I've asked her if we could provide everybody with a copy of this separately. It's not going to be on the website. It will be given to the committee so that you have it to work with. And as these numbers change, you know, this is obviously 2021, 2022. When we get to July of this year, then we can do the 2022, 2023 fiscal year. and look and start looking at trends. So I am going to actually stop sharing this for a moment. If I can find my little X. Okay. Feedback. I am looking for thoughts, ideas. Yes, Rachel.
So, I'm here as a representative of the International Association of Forensic Nurses, and one of the conversations that we had with some of the leaders in that organization was the disparities of, cases based on population. So, looking at that list and knowing the populations of like Hartford Hospital and say like Bridgeport and other places, some of my concerns, and maybe Beth can speak better to this about numbers, but, not necessarily where the greatest number of exams are, but where there should be exams that aren't being done, So when you look at the states and the towns based on population and knowing the ratio of, expected cases, looking at where we should see numbers and where we're not seeing numbers, maybe those are the places with the greatest need. If that makes sense, or if anyone wants to weigh in on that, because I think it's hard looking at the numbers, and seeing different things. The more resources you have, you'll be able to target those places as well. Because I think that's a big fear, when you don't have nurses in a place. It may be rural, but you're missing people. I look at Rockville knowing that, you actually have a decent number of safe nurses, that are heavily involved. And for that little hospital to have 5 cases, I think that goes to show because they have a resource there, So I think it makes a difference having the availability.
Beth, what's your thoughts on that? I mean, I think Rachel has a good point, but I don't know what your numbers look like, and I have not asked for the numbers, but this is just part of the conversation.
I mean, I'd be happy. I don't have all that stuff in front of me now. I'd be happy to provide, some data on where we see folks. I think it's kind of both and is the challenge, right? I think you want to use the program to both encourage and do education that would increase in places where survivors need services and maybe just are not utilizing or don't know about the opportunity to have evidence collected post-assault. I also do think, sometimes it's about, creating more success. So if you have places where you can have a champion and you can go in and you can set up a program and use that as a model for other folks for expansion, I think sometimes that's also a really strategic way to go about it. So I think there's probably multiple layers. My guess is as you gather this information and the process that you talked about in, sort of gathering, sounds like data and people and thoughts, right, together, I think you're probably going to tease some of that out anyway, and probably will be able to, thinking about our services, thinking about things like DCF, the MDTs and CACs in the state, if you gather all of those as data points, you'll be able to probably do both, right? To really identify where things aren't happening that should be, and then to identify where there is a lot of support or, stuff that is needed. And I know actually I'm saying kid stuff, and this is probably not all kid stuff anyway, but it would be interesting to overlay, right, some of that data. The challenge is, right, that in general, I think there probably is a lack of knowledge about the possibility of folks doing this and what the process looks like for most people, right? Like most people experience television as a primary source of education about this, which is not accurate or has nothing to do with Connecticut, right? So, I mean, I think overall there's lots of, great opportunities for reinvesting in the program and reinvesting in, just awareness and advertising, quote unquote, in general.
Other thoughts? So one of the things that we had to kind of sort of go back to is and we may be doing this at the next meeting, is I think we need to go back and revisit what the statutes say specifically, and what the intent of the statutes were intended to do. I know that, you know, back in 2009, when 2009-3 was passed that established the SAFE program, everybody was working off the best knowledge that they had at the time. And one of the issues had been in those days was it was kind of assumed that nurses would want to be a part of such a program. When the reality is that a lot of nurses want the training, but not necessarily to be part of a 24/7 on-call program. And yet, I heard it from, I know Mariel's not here, but it was something that she noted on behalf of the Connecticut Hospital Association at the January meeting, was that they believed that it should be a response program. And in the annual competency days, I do hear the stories of bare-boned ER staffing, where you might have a small handful of nurses on the floor, and a patient who's reporting a sexual assault walks in, and now you've taken a nurse off the floor to take care of that, and to take care of that patient. And so in one of the things about putting things in statutes, and I know Denise Poncini, you'll correct me if I'm wrong here, but when you put things in statute, you can't really change them except by going into the statute and going back to the legislature. That's not an easy thing to do. So we often are bound by statutes, whether good or ill, because they're just there. But I do know, as my understanding of 2009-3 or 09-3 was that the intent was a statewide expansion that was to include all the hospitals in the state, not really understanding the realities. And part of what this committee might need to do is to look at whether or not that statute needs to be revisited, whether the legislature should revisit it at some future point in time, in order to accomplish what should be the goals of the program, which is having victims of sexual assault should have the care that a SAFE can provide consistently. And I know that we have many community partners and voices, including those on this meeting, who want SAFEs to be the standard of care everywhere. And so this committee is being tasked with that. And in the yes, the pamphlet will still be on there until we can wrap that up and get our statewide discharge packet. Those two things will be on there. But in moving forward, you're going to see the agenda being broken down into the different components that need to be addressed. What should the structure of the program look like? The one thing I can tell you is that it really shouldn't be in just 8 hospitals and nowhere else. That's the one thing I can honestly say. So I think Alexis had.
Sorry,
Honestly,
I was just, I mean,
go
I
ahead.
worked last night. This is obviously loaded subject, and we want all these patients, people to have support and care. But what is happening in emergency departments is absolutely unreasonable for this in just resources, etc. I mean, I cannot take care of 50 patients, 2 of which come in saying that, they've been sexually assaulted, one of which it's her 3rd kit for the week, and not have a SAFE or really have a serious response, or the person who comes in 2 days later saying, she went to see her ex-husband and stay over and he was massaging her, and then you know, she said no. And I mean, to tease out this stuff in an emergency department, these are not people who've like clearly like violence or problem. Like, I don't know that the emergency department is the best place with everything. And I think that legislators want to do and say and make laws, and they really don't have very good knowledge of what is possible, what is reasonable. Where are we going to get this? Like, you can't even take care of a person who's dying. Like, I mean, you know, and I do like, I think that it's when you practice long enough, like, of course you want the best for everybody, but there's triage. I mean, there just has to be like, and if I'm the, you know, asshole who says it, like, fine, but like, I'm also working it and trying to figure out how to meet expectations and care for all patients the best.
Rachel?
I think it helps to put it into context with something that's maybe less volatile. So if we were to say this was a chest pain patient, like, you wouldn't say that you wouldn't give the chest pain patient the minimum standard of care to determine whether or not it was an actual MI. And I think that we have to remember as nurses that our job is not to investigate the patient's story, and that you need to remember that 100% of the time, the patients are survivors of their own trauma, but that the criminality of the events is not something that, as nurses providing care for a patient, that is our determination to make. So I think that if we talk about a minimum standard of care for any patient reporting sexual violence or assault, that the sexual assault exam, the medical forensic exam, is the minimum standard of care. So rather than saying whether or not they need it is not really the question. It's how are we going to get the patient this minimum standard of care, which is the medical forensic exam and the collaborative points that they need. And that is the standard of care for those patients. Just as an EKG and, you know, and things would be the basic standard of care for patients, you know, at risk with those things. And it is patient driven. So I know it's a hard topic, and I know, like, I'm not trying to, like, and maybe I'm just playing devil's advocate with the point, but I think that, you know, acknowledging that it's the minimum standard is maybe a spot to go there, and then we have to provide it. So let's figure out a way from there to deal with it in those scenarios, you know, with whatever support, you know, is best for all the health systems or hospitals or wherever.
Yeah, I mean, we can agree to disagree, but I don't get an EKG on every chest pain. Like, that is why I went to school, and that's why I practice. Like, that's the art of medicine, is determining what someone needs, and you have to get a history and physical to kind of say what is going to be the minimum standard here based on medical decision making. So no, I don't believe everybody needs a sexual assault kit. Yes, somebody who reports it desires that there's some component of, sure, there should be a minimum standard. And I don't think anybody would not do it, but the resources to get it, I mean, they may be waiting 12, 16 hours, and there aren't safes. There's a, you know, PGY1 who's going to try and figure out with, like, the nurse who just graduated, like, doing swabs and whatever. That's all. I mean, I'm just saying, like, there are some lofty aspirations here and expectations, just like getting a EKG on a chest pain when you have 60 people, like, waiting is a lofty expectation. It's not going to happen unless you have, you know, 40 PCAs. I mean, it's all relative, I guess.
Very interesting discussion. And you know, I think that one thing that can be said for sure is that since 2010, we have at least established a standard of care, the gold standard of care, if you will. And I think that is the SAFE. And I recognize and understand that healthcare is not trained, and not everybody should be a SAFE. I know Linda and I had this conversation at one point, and I rarely put the kibosh on anything that would create more SAFEs, but the idea was that all emergency department personnel should be required to do SAFE training. And I pointed out, aside from the sheer impracticality of that idea, hospital, it costs money to take somebody off the floor. And I recognize that. But more than that, we have victims of sexual assault who work in hospital emergency departments. And this would be a triggering event for them. So it's not appropriate for everyone to be trained. That means there has to be a choice on the part of hospitals as to who is going to be trained to be safe. And it's really an individual choice at the end of the line, and from my perspective. But at the same time, what we did was we created a standard of care that was available to some, and we still don't have it available to everyone. We are working on that. I'm hoping that by this time next year, we will have memorandums of agreement with everybody and can maintain those to at least allow the staff who are currently not under MOA. I had a request yesterday from a nurse who wanted to attend the class, but her hospital was in a hospital system not under contract. And I had to say, I'm sorry, we're working on that. And hopefully by the fall class, but I had to actually say, I can't have you in the class. So that's one piece of it. But what we would like for this group to do is to really have these kinds of hard discussions but come up with here's what we think should happen solution, even if it's not a best fit, even if it's not ideal, but so that we can have safes available, at least have hospitals have the choice of having safes available in every hospital.
I mean, there's no doubt a safe is better than me, a resident. I mean, there's no doubt. It's just getting them, right? I mean, that's what we've been talking about for the years that I've been on this committee, right? Is getting them, retaining them, having them continue, getting them on call, who's paying them, I mean, right?
Yeah, so I will say this, not sure if Sherry's still on, but Sherry Watson, I think really helped an incredible amount when she had the idea of allowing us to have access to the Connecticut Nurses Association and the Connecticut League for Nursing. Mass emails were sent out to both groups. And we had many inquiries, far more than I ever expected. I think I counted at one point nearly 300. Not everybody came into the program. We don't have the resources to train that many. I actually almost panicked when I saw that many. But it has allowed us to bring in other than ER nurses, and they have been phenomenal. I kind of sort of had almost a question mark in my head. Well, okay, but some of our best nurses, some of our best safes are outside the ER. They do phenomenal. And especially, I had one, we're starting to bring in males, and I had one male who came from a hospice background. He did hospice. The models all talked about he was the best one. Patients love his manner, and he's very gentle, and I think that the training, although obviously room for improvement, I think the training is solid, and I think that as we continue to look beyond the ERs, I think we have, I mean, we have public health nurses, we have not just hospice. I have another one from hospice. We have all kinds of backgrounds coming into the program, and these are people who want to be safe. And what's very interesting is that some nurses have been victims of sexual assault, and they talk about their safes, and they want to be a safe because of that. That's new to us. So I think that in terms of staffing, it's going to take time, but I think it was one of the best things we could have done was to look in other areas of healthcare. Outside of the emergency department, because those who are in the emergency department already do these things. And you know, we always say the SAFE program is an extension of the emergency department in that respect. So I'm hoping that the trend that we have seen over the past year, I'm hopeful will continue, and we will continue to grow.
Can I jump in for 1 sec?
Oh, yeah.
Which is, sorry, pivoting back a little bit, but I feel remiss if I did not say part of what I'm thinking, which is that right now what survivors experience are an incredible number of barriers, right? They experience police who try to triage in some of the ways that were talked about earlier. And very often what that means is that folks who are from some of our most vulnerable communities, survivors who are difficult, right, to deal with and to have to work, you know, through a process with, who are not easy, those folks get left behind, right? They are folks that do not have the police reports taken. And what scares me a little bit about the conversation is if we start to move towards a place where we are triaging versus offering something that should be readily available to everyone, then what happens is that lots and lots of people will not be able to participate and therefore will not have any accountability whatsoever when it comes to folks who have caused them harm. And I think there will be definitely patterns, right, of who will fall into those categories. When I did this work directly and I worked with survivors, sometimes it could be somebody who comes in stone-faced and not emotional and they are not believed. It also were folks that, you know, who came in who were known from having mental health issues or being homeless, who were told, oh, no, you can wait over here. You know, we're not really sure. She was just in for something else the other day. We don't believe her. And in reality, right, in all of those cases, these were women who were sexually assaulted, right? That was their experience. But the message that they got and that I got as an advocate sitting in those spaces from those providers was that they weren't believed and that they did not belong in that setting, right? So my fear is, and I cannot imagine the difficulty of doing this work now, especially through what has happened in our world, I shouldn't say our country, in the last several years. I can't imagine being a teacher. I can't imagine being a nurse or a healthcare professional. I understand the mass exodus that has happened, but these are people who are especially vulnerable, right? And who need a level of, I really like the way that, you know, Rachel talked about the minimum standard, the level of care is having a safe, you know, provide folks with this resource. It literally broke my heart a little bit, right? To hear folks talking and to hear the same things we hear, you know, from folks working with law enforcement in this setting. Because the other thing that I know to be true about myself and about the survivors we work with is that negative interaction, that person in that position of authority not believing them, means that they don't go to their primary care physician, they don't go to Planned Parenthood, they don't do any follow-up care, right? Because the message that they have internalized is that nobody's going to believe me or I'm not worth people's time. And I've been somebody who's experienced that myself, right? And it literally impacted for a decade how often I went to a doctor or a dentist or anybody else. So my fear just is like the extreme amount of power. It might not feel like you have a lot of power in a medical setting, but or in that space because it feels like you're very disenfranchised. But the amount of power that has on the trajectory of a survivor's life and the care that they seek is really, really critical from where I sit. So I don't know if any of that is helpful or not, but I'm sorry if I'm taking us backwards a little bit, but I just really wanted to share that perspective.
Thank you, Beth. I appreciate it. And this is these are the kinds of discussions that we really need to have in order to get to the nuts and bolts of what it is we need to be doing. Amanda, I know you had your hand up too.
Yeah, no, I just kind of wanted to throw in, I know at the Alliance we had a training, I think it was last summer, about trans survivors. Well, I think LGBTQ survivors in general, and we had some healthcare professionals who came in who I think they provide primary healthcare services, and we were kind of talking about the barriers that LGBTQ survivors and also especially trans survivors for coming into, I mean, probably any hospital setting, but especially to come in for a sexual assault forensic exam. So I just kind of wanted to highlight in this meeting that I'm hoping for future conversations that we have about this, that we are kind of considering those barriers for other marginalized groups as we kind of navigate and figure out solutions to how we can provide this service everywhere. Because yeah, there may be survivors, as Beth has also just said too, that they might not even walk into an emergency room. So if that's like a discussion that we could also potentially be having, whether it stays in emergency rooms, yeah, just kind of wanted to elevate those conversations that happened last year and the voices that aren't in this room who are being impacted by this. So.
Thank you, Amanda. Rachel?
Denise, I was hearing something that you said about having people now approach you to be in the training program, but not being able to accommodate them because there aren't enough spots. Was that correct? Did I hear you right in saying that?
It's really more about contract. I mean, Denise Poncini, do you want to kind of explain a little bit?
Sure. So we have a certain number of participating hospitals where the judicial branch sends safes in when requested, but there are a number of other hospitals that have MOAs with the branch that allow them to send their nurses who they select to OVS for training to become a safe. And then they just go back to their own hospitals and they're able to provide that service with those hospitals. But we can't train a nurse who works at a hospital who has not signed this agreement with judicial. So those people, even though they might be willing, we can't train them.
Oh, I thought you guys were still offering training if, say, anyone wanted to be a safe in Connecticut, but that's not the case at all.
It's all hospital centric. Would you agree, Denise?
I'm not quite sure what that means, to be honest with you, but what I can say is that, for instance, Hartford Healthcare, Yale New Haven Health Systems, Trinity, all have signed as hospital systems. They have signed MOAs. We are working with Nuvance. This was a Nuvance. This was a hospital under Nuvance. They do not yet. They're in the process of working on an MOA, getting that MOA signed, and as Denise would say in legal parlance, fully executed. There are most of the hospitals in the state are within hospital systems. There's a handful of that are not. For example, Middlesex Health is its own hospital. Stanford Health is its own hospital, but it's a system by itself. There's not really that many hospitals who do not have a contract. I think if we were to count it up, it's more than 80% of the hospitals have contracts, but just the ones in Nuvance don't, and a couple of other ones. I don't want to name them, but there's 2 individual hospitals that currently also do not have contracts, and one of them their CEO has been very clear. They don't want one. They don't think there's the return on investment is there, and they can't take their staff off the floor.
But the thing is that for the problem within Connecticut, it feels like the numbers, like having the resources of safes within the Connecticut is the problem, right? Not having the number of safes to be able to move forward. Is there any opportunity to open up training to just the entirety of Connecticut, or at least approve another means of training for those that can't be trained through the judicial branch, to at least expand the number of resources within the state? Not take over, but maybe I'm thinking of the IFN, offering at least the option or advertising the option to those that are not within their, hospital systems or, health systems as individuals as a resource?
Well, one, it's in statute, and it would take a change of statute to open that up. But two, Public Act 19114, which kind of sole sourced this as the trainer for the state, was actually put into play partly because when you have multiple sources of training, you have multiple sources of information, and it didn't allow for that consistency or reliability, which was very important to basically all of our community partners. We're not really limited in terms of the number of people we can train. If necessary, we could do it virtually and train 200 people. But we're working on getting our models and an instructors program in place, and we are growing that. But at the same time, it's really more, to be honest, it's really hospital limited. I've been practically, the spring class, let me put it this way, the spring class starts a week from Monday. We've had the application out to more than 80% of the hospitals in the state, and I have had hospitals who have turned down the invitation because their staffing is so strained that they can't take staff off the floor. And in fact, I had 2 applications in that were pulled back by the hospitals this week because they took a second look at their staffing needs and felt that they could not allow those nurses to attend the class. So it's really not so much limited by us as it is limited by hospitals themselves and the MOAs, which I expect a year from now. My goal a year from now is to have all the hospitals under contract so that nobody is excluded. I shouldn't be getting emails like that where I have to respond the way I did. But really, the limiting factor is the hospitals themselves. Does that make sense?
You know me, I want everybody to get trained. I want the hospitals not to have to pay for it. I want, if an individual wants to be as safe and take that initiative to grow within their own nursing practice, have that opportunity. So it'd be interesting to see if there was something on an individual basis, and again, I think it's the whole going into the state contractor, like as an independent contractor, you're able to train that way. And I get promoting that, but I do think with this generation, especially, it's very hard people value their individual time so much. And not to say that that's a bad thing, but, second and third jobs are not as common as they were years ago. So, being able for them to do it on their own and enrich themselves might add another avenue to receive the training from the state, but not have that financial burden on the hospitals where the person, works around it, so.
Yeah, it's really tough. I mean, we did try to address that. The course itself, I don't know, Rachel, if you recall, it used to be, I think it was at one point, it was like $600, and then we dropped it to $400. And then thank you to Anna Fiddick, our accountant, she figured out we could offer the course at no cost. But as one hospital ED director pointed out to me, even though we offer it for free, they still have to let the nurses off the floor. It's still at cost to the hospitals. You're on mute.
I just said definitely.
Yeah.
And especially if they're getting paid their hourly wage while they're there doing the training. So it is a commitment, but it seems like there's a lot of individuals out there that would be willing to, step up to. I don't know. It's just a feeling more than an actual tangible data point.
Yeah, it's not a data point, but I will tell you, I have had several applications from nurses whose managers would not sign off. And they have to let them off. You can't allow them, it's not fair to anybody to allow them to sign up for a course that they then can't be present to take. Other conversation, because we kind of got a little bit off on a tangent there. But really over the next couple of years, this group, and we're going to kind of sort of divide it up, and what's the saying, divide and conquer. We're going to continue these conversations and try to really work out. I think we've established the need for safes. I don't think that's in question. So then the question becomes, how within the limits of the statutes, how do we get this standard of care, this program, as a response program within the state? And Rachel, I think you had a good point about where the numbers aren't. I would, but also I think the other side of the coin is why, because your numbers, Yale's numbers stand out head and shoulders. The question then also is, how come? Why are those numbers so much greater than Bridgeport, so much greater than Hartford's?
I have a
Is it because Yale has 25 or so safes and it's known? So therefore, victims of sexual assault go there versus somewhere else that doesn't have the safes. So these are the kinds of things we want to really think about as we go forward and as we move forward and start to come up with a plan. Other thoughts? And I'm going to pose one last question. Is there anybody who thinks this conversation, maybe let me reword that. Is there anyone who thinks would be opposed to this being the mission of the Safe Advisory Committee? Do you think the Safe Advisory Committee should go in a different direction? Okay, so that kind of sort of focus, it pretty much not only defines the focus, it confirms that the focus of this group should be expansion, getting safes in every hospital, getting the response program across the state in to the degree that is practical to get. Any last thoughts under new business? Because I did put this under new business, but I want to know if anyone has any other new business. Okay. Hearing none, we will adjourn the meeting at 3:10. And I want to thank you all so much for your time and for the discussion. I think it's given us a lot to think about. And our next meeting is May 10th at 2 p.m. Have a good rest of your day, everybody.
Thanks,
Thank
Denise, you
you.
too.
Bye, everyone.
Bye.